introduce our second presenters. Today, it's going to be another joint presentation between my colleague, Melissa Statham, and another one of Oak House physicians, Dr. Pravesh Janungdan, on osteoarthritis of the hip.
Hi, good morning. Thank you, Trevor. And I thank Melissa, my co-presenter, for inviting me to present with her. My role is to do just the overview on the anatomy, physiology, and some of the pathology. What you will hear is that the pathological mechanisms are similar to what was discussed earlier on in the earlier presentation. So I won't spend too much time on that. I'll touch on it. So osteoarthritis of the hip, why is it important? Because it affects our mobility and quality of life. So that's the basic thing. It affects your mobility and quality of the life. So this is the anatomy of the hip. It's made up of the pelvis and the femur. So when you're standing and you hang your hands down, it's the two joints on either side that allows you to walk. It's a pelvis, it's a acetabulum, and the femur bone. Next slide, please. That's just a schematic of the same thing, so it gives you some perspective. So the next slide demonstrates the joint as a ball and a socket joint. The socket is, if you just think about, a round ball and you cut it in half, that empty space is the socket, and the ball is the normal ball that fits into this. Next slide. An everyday example of a ball and socket joint is what we have in our bathrooms, is the shower head. And we all know that this is a very highly mobile device. You can move it almost in any direction. And that's the ball and socket joint. If we go to the next slide, it gives you a detailed view of the pelvic bone showing the acetabulum. This is the cup that's lined with cartilage. The next slide shows you the long bone in the thigh. That's the femur. And the ball is at the top end, the head of the femur. As you track down, the distal end of the femur articulates at the knee joint. So the femur connects at the top with the hip joint and at the bottom with the knee joint. This is important because anything impacting one joint is more likely to impact the other joint because the mechanisms all changed when either joint is not functioning well. In the next slide, we'll see that the ball and the socket are covered with articular cartilage. This is, as was discussed previously, a slick, spongy covering that allows one side of the joint to slide against the other joint surface easily. The fluid between both these cartilages, ovular fluid, think about grease in the pistons, that in your car pistons that allow it to flow very freely. And as we previously heard, there's no direct blood supply to the cartilage. The blood supply comes via the bone and it soaks through from the inside tuberculi. The nutrients come from the synovial fluid that lines the joints. So therefore, because there's no direct blood supply, we find that the cartilage has limited capacity to repair. And once it's degraded and lost, it's not replaced to any measurable degree. So being a ball and socket joint, as I said, this is highly movable in all directions: forward flexion, backwards extension. Turning your foot inwards is internal rotation. Turning your foot outwards is external rotation. Moving your leg away from the center of the body, abduction. Moving your leg towards the other leg, adduction. And we often see when we watch gymnastics or dances, highly flexible hip joints. So when we have a patient with hip pain, what is our differential diagnosis? So there's many things, and obviously the age of the patient makes a difference. And some of the things we think about commonly is a trochanteric bursitis. Usually they will present with pain on the outer aspect of the hip. This is inflammation of the bursa. It's where the tendon slides over the joint. And because of some unusual or repetitive movement or direct trauma, the area can become inflamed and can cause hip region pain. Inflammatory arthritis, for example, rheumatoid arthritis, you can get pain in any joint. A septic joint, this is obviously something quite important and urgent that needs treatment. Typically, the joint will be red, hot, swollen, and the patient themselves may have a fever. So this is something you want to diagnose very, very early and treat them promptly. Osteonecrosis is destruction of the hip joint, usually in the younger patient where the blood supply is compromised. Femoroacetabular impingement, also where the foot of the head and the acetabulum is not correctly aligned. Again, this tends to be in the younger population. Crystalline disease, for example, gout. Lumbar radiculopathy and lumbar spinal stenosis. So basically what's happening here, we are getting referred pain from the low back region, either pressure on the sciatic nerve with lumbar radiculopathy being transferred to the hip joint, or pressure on the spinal cord itself being radiating to the hip joint, either one or both joints. Obviously, we're worried about cancer. This could be a primary bone cancer in the region or a soft tissue cancer, or it could be a metastatic cancer, for example, cancer that spreads from the bowel or the lungs to the bone, and that could be your first presentation. Myalgia paresthetica, this is pressure of the superficial nerve in front of the thigh. Typically, the pain is in front of the thigh. It could be a numbness pain, tingling, related to direct pressure. So, workers with tight belts, or if you put on lots of weight, or your job involves, forward bending constantly and applying pressure in this area. Iliotibial band syndrome is pain on the lateral aspect, outer aspect of the hip, very similar to trochanteric bursitis, just extending further down. Vascular claudication relates to the blood supply in the area. Usually these people will have multiple other medical issues, for example, diabetes, high cholesterol, etc. So in hip osteoarthritis, this occurs when the cartilage in the hip joint wears away, leaving less protection for the bones. As the unprotected bones rub together, they can damage each other, causing pain, inflammation, and stiffness. Ultimately, the joint will fail, limiting mobility. Generally, 1 in 4 people will develop hip osteoarthritis by the age of 85. The risk of osteoarthritis is similar for people of different races and sexes. The condition occurs most often in older patients, but younger patients can develop hip osteoarthritis, usually after a joint injury. Although destruction and loss of the articular cartilage is a central component of osteoarthritis, all joint tissues are affected in some way. This indicates that osteoarthritis is a disease of the joint as an organ. So more than the bone and the cartilage, they are talking about the synovial fluid, the ligaments, the tendons, and the muscles. So everything around the joint gets affected. Stage 1, you may not even know you have the disease or the condition. You may have no symptoms. If at worst, you may have little pain or stiffness for a short while. There may sometimes be a bony spur. And osteoarthritis can affect one or both hips. Usually the x-rays, if done, they do not correlate to function or pain impairment experienced by the patient. So what you see in x-ray does not always correlate well with the level of pain or level of function that you see. In stage 2, this is mild hip osteoarthritis. You are more likely to experience hip pain and stiffness, especially in the morning or after sitting, that is a static posture. Initial steps may be difficult, but the pain usually subsides once you start moving. Once again, x-rays may show some bony spurs, but the space between the hip joints is still adequate. In stage 3, which is moderate osteoarthritis, you're more likely to experience more pain and stiffness, especially when you start moving and with activity. Going up the stairs or downstairs or standing for long periods or walking for long periods can be bothersome. Prolonged activity leads to more swelling and inflammation due to larger bone spurs, eroded cartilage, and more narrowing of the space between the hip bones. Sometimes you may hear patients complain of a popping or snapping sensation. Stage 4 is severe osteoarthritis. There's gross loss of joint space with sclerosis and cyst, marked deformity of the femoral head and acetabulum, and large osteophytes. There may be constant pain, stiffness, even when you're not active. The pain can be severe. The pain can disrupt your sleep. So this is end-stage joint disease. The next slide just demonstrates X-rays that shows, normal joint space, and the one on the right showing you an osteoarthritic joint. So in terms of symptoms, there could be swelling, tenderness, grinding or crunching sensation, pain in the groin or the thigh that radiate to the buttock or the knee. So the pain doesn't have to be localized. Pain that increases with activity, stiffness of the joint that makes it difficult to walk or bend, locking or sticking sensation, decreased range of motion that affects walking. It may cause limping, increased joint pain, usually in damp and cold weather. So how do you diagnose osteoarthritis? Usually the first thing is on your history. You want to know what's the nature of the pain. Is your pain intermittent? Is it constant? What aggravates it? What improves it? You want to know if there's any specific trauma. Obviously, the age group of presentation is directs your history. I mean, a younger patient versus an older patient. Older patient is more likely to have osteoarthritis. During your history taking, you want to exclude other important medical issues, for example, an infection. You want to exclude cancer. Is it a primary or secondary cancer? You don't want to miss these things. You want to exclude other inflammatory conditions, for example, rheumatoid arthritis, psoriatic arthritis. You want to exclude referred pain to the area. Is this pain coming from the lumbar spine? Is this pain related to the trochanteric bursitis? So the history is of vital importance. Typically, in a medical evaluation, the history guides your physical examination. So your physical examination is more to confirm your suspicion already made after you've done your history. And it's to find other unusual, unexpected things when you do the physical examination. So during the physical examination, there may be decreased range of motion, there may be tenderness, active and passive range of motion may be decreased, there may be crepitus, there may be pain when you put pressure. You'll have to look at your patient walking and the gait may be altered. So once you've done your examination, you'll want to do imaging studies. Usually the imaging study of choice is an X-ray. X-ray is quite a good first-line tool. Nowadays, we have much more readily and quicker access to ultrasounds. So the ultrasounds is also important to exclude your trochanteric bursitis or any muscle tears or ligament inflammation in and around the hip joint itself. But obviously, if you're highly suspicious that it's osteoarthritis, and if that's confirmed by your X-ray, that's where you're going to stop. Sometimes, like I said, the X-rays may not always correlate well with the patient's symptoms, and then you may need further studying, for example, a CT scan or an MRI. Non-occupational causes, these were discussed earlier. Gender, the older you get, the more likely you to have osteoarthritis. Sexual occurs more in females. Osteoarthritis affects about 10 or 25% of the adult population at 60 plus. Family history is important, tend to run family. Obesity. There's more stress on the weight-bearing joints, both the hips and the knees. And we think that obesity may also lead to inflammation, and the inflammatory process may cause joint damage. Obviously, a history of previous injury is important, joint malformations, usually in the younger people. Lifestyle is important. A sedentary lifestyle, static postures in the joint all the time, or high impact activity. Other diseases, rheumatoid arthritis, gout, can result in osteoarthritis. Overview on treatment. So basically, when it comes to treatment, your aim of treatment is decrease function, at least decrease pain and increase function, improve quality of life. So whatever you do in treatment, the goal is to improve the quality of life. So you don't want to offer someone that has a very poor quality of life, that's kind of bedridden or wheelchair bound, any significant treatment of the hip, because you're not going to do anything with the quality of life. So for the average person, increase function, decrease pain, improve quality of life. First line treatment is education. So you want to educate the patient about the disease, the prognosis, the progression, etc. Physical rehabilitation, working on an exercise program with a physiotherapist that's goal orientated, is very important. This helps to strengthen all the muscles around the hip joint. It helps to improve function and decrease pain. This should be a formal program with specific outlines and specific goals. Assistive devices are important. You may need a walking stick or walker to help you along. So that is the first line treatment, is education, non-pharmaceutical, which is your assistive devices, physical therapy, activity modification. For example, if your patient is involved in high impact sport, you want to probably tell them, you want to give up long distance running, maybe you want to do swimming or cycling, which is less impactful on the joint. So conservative management first. The second line treatment is pharmaceuticals, over-the-counter Tylenol, anti-inflammatories taken on a regular basis. That's if first line failed, then you're going to move to medication. You can move to prescription anti-inflammatories on a more regular basis. And either that works or doesn't work. If that doesn't work, cortisone injections, ultrasound guided cortisone injections into the joint has proven to be helpful. It gives you more time before you replace the joint. So it buys you some time. It's not going to prevent the process and any eventual joint replacement, but it's a stopgap, and it improves quality, gives you enough time. Viscous supplementation in injections into the hip joint has been found not to be helpful. So cortisone is the only thing. And if that fails, then it's a referral to an orthopedic surgeon for considering of a hip replacement. And this is a schematic of what I just discussed. So in the next slide, in terms of hip replacement, you can have a total hip replacement where the damaged part of the hip joints are replaced with artificial implants made of metal, plastic, or ceramic. You can have hip resurfacing. The damaged surface of the hip joint are removed and replaced with metal in order to restore joint function. Osteotomy is where the bones of the hip are realigned to redistribute weight and reduce stress. The osteotomies are usually, there's not a good fit between the ball and the socket, seen in younger patients. So they will realign this where the fit is better. The next is just a diagrammatic representation of a hip replacement. You can see both the cup and the ball is replaced, and the ball is anchored with a large screw going into the femur. On the right is a total hip replacement, and on the left is hip resurfacing. And the next slide is also just some, imaging studies of hips that literally been screwed on, and exposes the surgeon to lots of hand arm vibration when they're drilling and hammering into your body to do all these things. So that's my overview of just some of the anatomy and physiology, a little bit of the pathology, hopefully helpful. I'll hand you over now to Melissa.
Thank
you very much.
I'm going to address now more of the occupational causes for hip osteoarthritis. Just going to move this out of the way. So, looking at some of the online resources, just some reputable sites as far as occupational causes. Profesh went through the causes that are non-occupational, but what it's saying is that John Hopkins indicates that hip osteoarthritis can be from overuse. So, jobs or sports that require physically repetitive motions that place stress on the hip, it can increase the risk of osteoarthritis. The Mayo Clinic indicates that repeated stress on the joint. So, if your job or the sport you play causes this repetitive stress, it can eventually or may eventually lead to the development of osteoarthritis. The Arthritis Society of Canada indicated that people who repeatedly experience stress in a particular joint or who perform heavy physical labor may also be at a greater risk of developing osteoarthritis. They give examples of dancers, heavy machine operators, and construction workers. So, in researching for this presentation and looking at the different occupations that have higher rates of hip osteoarthritis, some of the common occupations seen were healthcare, housekeeping, service industry, agriculture, fishing and forestry, mining, construction, and food service. So, when looking at these different industries, some of the things in research that had in common as far as the risk factors that could lead to the development of hip osteoarthritis were heavy lifting and carrying, stair climbing, full body vibration, forceful exertions, kneeling, squatting, bending, repetitive arm movements, and standing. But one of the common themes out of all the research that was a huge predictor of hip osteoarthritis was heavy lifting and carrying. So the side here you see that I have a note that is important is that some of these studies that suggested that there was no increased risk of hip osteoarthritis with certain amounts of walking, sitting, and standing. However, there was a research that then also suggested. So it's important to kind of look at all of it. But a common theme across all the research that I looked at was this idea of heavy lifting and carrying being a primary risk factor in the development of hip osteoarthritis. So, some systematic reviews that I looked at was Yan in 2024, who found that occupational mechanical exposure, so lifting, carrying loads, walking, climbing stairs, non neutral postures, kneeling, squatting, standing, walking, and a combination of any of these seemed to influence the likelihood of developing hip osteoarthritis. Selsky in 2012 found that there was evidence that identified heavy lifting and standing as hazards for hip osteoarthritis. Umvers in 2024 indicated an association between various occupations with high physical workload and an increased risk of developing hip osteoarthritis. And Franzen in 2011, in a long-term exposure study, found that heavy lifting was a significant association in developing chronic hip and knee pain. In a longitudinal study that was 22-year prospective study that looked at risk factors predisposing for hip osteoarthritis, they gave a health survey in 1978, 1980, and then re-examined these people after exclusions in 2000 and 2001 and found that hip osteoarthritis was diagnosed in 41 subjects. They found that heavy manual labor predicted the risk of developing hip osteoarthritis, and permanent damage as a consequence of any musculoskeletal injury was also an independent predictor of hip osteoarthritis. So, when we look at all of this, and we know that there is this um, risk factor of heavy physical labor or heavy physical forces that can lead to the development of hip osteoarthritis, we kind of go to this hierarchy of controls. The hierarchy of controls is an inverted triangle starting at the top with elimination being the most effective control, all the way down to personal protective equipment, which is the least effective. When we look at elimination, it's the removing of the hazard. Substitution, it was replacing that hazard with a lesser hazard. Engineering is something that can be built into the design phase. Administration, administrative, developing procedures so the work is conducted in a way to minimize the hazard. So, an example of this would be training. And then personal protective equipment is anything the worker wears to protect themselves from the hazard. For example, gloves. So, when looking at the risk factors of hip osteoarthritis, the literature pointed in the direction of heavy lifting and carrying as a dominant occupational factor. So, taking this into consideration, I then looked at different work sites I had been to and how, I could use this hierarchy of controls at each level and apply it. So, in this example here, you can see someone bending into a gaylord, lifting out a pail of regrind plastic. So, what they would do is every so often they lift this pail, and in the third picture here, you see a hopper. They would dump it into the hopper. And this process was done, probably a few times every hour, but it was causing some, musculoskeletal discomfort. And then, which brought them to, kind of seek some help. So when I went in there, one of the first questions you always ask is, why does this process actually need to happen? Does this, you're lifting it from one area to another area very close together. So the recommendation here was made to just have the gaylord of refined plastic be put in place of the hopper, removing the hopper completely and putting the vacuum right into the gaylord of refined plastic, eliminating this entire process from needing to be done. The use of substitution as a control involves replacing a hazard with any lesser hazard. So, in this example, you can see the picture of bins to the right here. And this was in a donation facility. And what they would do is they would be getting a lot of different metals. They would organize the metal according to bin. And based on how full they felt, they could lift, they would then remove that bin from the rack and carry it over to a shipping area. So, this idea of carrying and walking with different loads was flagged as a hazard potentially to develop some type of musculoskeletal disorder. So, the recommendation was made that the sorting be done directly into these bins, and then rather than carrying and lifting, they would then be pushed to the shipping area. Engineering controls are built into the design, and this is an example of a cart that had 500-pound weights loaded onto it. And what happened is that this worker was in a hospital, and you had to go and calibrate the scales throughout the hospital. As you can imagine, navigating the halls in a hospital, there's various patients, workers, equipment. So there's a lot of initial, like, stop and start. So with that stop and start, the greatest force is the initial force to get something to start in motion. And so there was a lot of initial forces being, in one path, just from point A to point B. The cart would stop several times on and off elevators. There was that lip. So there was high forces deemed to be unacceptable. And the recommendation was made to then use a power cart rather than using this manual cart. Administrative controls do not change the hazard, but they regulate exposure to the hazard. So, without making any physical changes to the work area, the equipment, the tools, or the work processes. One of the common administrative controls used in ergonomics is job rotation. So, it's important, just like I said, that it doesn't really address any of the hazard of the actual job. It's just going to limit the person's exposure to that job. The important aspect in any job rotation to make it effective is to ensure that wherever you rotate, you're not using the same muscle groups in the same way again. The idea of job rotation, the premise behind it, is to give those muscles a break to regain, blood flow. They've fatigued already. So you want to go to some task that's different, uses different muscles. And you see in this graphic here from MSD Prevention, it's showing a manual material handling process where someone's lifting a box, and then, the next process they're going to go do some inspection and visual checks. Then they'll go do assembly. So you can see how the tasks are very different. And so job rotation can be an effective tool to use if it's designed and well thought out. Another administrative would be job enlargement. So increase the variety of work that the worker is doing, and then training. Personal protective equipment is something that the worker is going to wear. So it's the least effective control. Examples of it, the first one up here, the picture you see is a worker wearing knee pads. So they're protecting their knees against contact stress, which occurs when you rest a part of your body on the hard surface. So it's kind of like it's giving them that layer of protection, but it's not changing anything about the hazard. Similar to the gloves worn here to protect against the vibration from the grinding of the tool. So again, this is kind of your lowest level of control. You want to ultimately try to eliminate anything that is going to be a potential hazard to a musculoskeletal disorder. So going back to like a case study that I did with someone that had hip osteoarthritis, and just kind of to back it up a little bit, for many that might not be aware, is that OCAL offers clinical service in which workers who have been denied any WSIB claims can have their file referred to our team. So our team of physicians, hygienists, ergonomists, nurses, CSCs, and we then review these files for work relatedness. So we're kind of combing through the files, kind of gathering evidence that although your claim was denied because they potentially said it wasn't related to the duties, that maybe in fact there is something there that really it was an occupational cause. So the study or the patient file that was sent to me was one of a police officer who had worked for 15 years at the time of injury and was diagnosed with hip osteoarthritis. The claim again was denied, similar to the one that you heard Trevor speak about and Cynthia, because it was a degenerative disease, it was gradual onset. It's a very common theme with almost a musculoskeletal disorder because typically it does take time. So often they get denied for that reason. So after all this literature I've researched prior, you see that a heavy exposure to heavy physical loads is something that is a primary risk factor in the development of hip osteoarthritis. So when you look at police officers, they're required to wear a duty belt, which weighs approximately 20 pounds for the duration of their shift, which is typically 12 hours. This duty belt, like, it can range, and there's also other, they're wearing their vest as well. So they're carrying weight all day. So when I looked at duty belts in literature, I found that Burner in 2024 that duty belts have a negative impact on the officer's ability to perform occupational task and movement, and officers reported an increase in discomfort associated with wearing duty belts while seated. Billing in 2015 found that for every kilogram of load carried on the body, physical performance was reduced by 1%. Dempsey in 2013 found that duty belts reduced officers' agility and ability to exit, pivot, and accelerate from a lower car seat. 2023 found that 88% of officers reported pain and the discomfort at the end of the shift, and most of these complaints were related to the duty belt. Another study found that the most common area of discomfort associated with wearing duty belts were the hips and the lower back. And Larson and Ramstrom, who investigated gait kinematics at the trunk, hip, knees, and ankles when officers wore duty belts, found that there was greater hip abduction and abduction when the duty belt was worn. So, taking this literature that was compiled, it supported the idea that physical heavy loads, including wearing duty belts, can contribute to the development of hip osteoarthritis. So, that information was taken along with looking at the physical demands, the other job duties, their work history, and a report was written and submitted. Basically, that the 15 years of exposure to these risk factors wearing the duty belt could have led to the development of the hip osteoarthritis. And with that, we can take any questions.
Thank you, Melissa and Pravesh. That was very, very informative. Okay, so the first couple of questions were placed in the chat while Pravesh was doing his talk, so I'm assuming that they would be directed more towards him. So, other than changing sleeping position, what would be an effective treatment for a right side sleeper if the right side hip joint without OA has started exhibiting pain during walking? Should they look at a softer mattress? Or would there be other physical changes that they could do to help improve this condition? Pravesh, if you're speaking, I think you're on mute. Still on mute. Hold on here.
Can you hear me now?
Yeah, we can hear you now.
Okay. So in terms of the mattress, there's two things. One is your mattress should not be hard, similar to a doctor's examination bed. That's extremely hard. The opposite shouldn't be true either, like a pillow top where your body sinks into that and your spine is curved throughout the night. So it needs to be something in between where it's sort of firm, but not too firm and not too soft. Specifically, if you're getting hip pain, and the other suggestion is what we call a wedge. Some people will use a body pillow, but that's more big, or sometimes you can get a wedge that you can keep on your right side, so that prevents you from putting all your weight onto your right hip. That's specifically to sleeping. Then obviously, if you're talking about other things, then I think the analysis of the gait is vitally important. Whether it's coming from your ankle, your knee, or your hip, you can end up with hip pain. We see that fairly commonly. People with knee complaints ending up with hip pain just because the biomechanics have changed. Improper footwear and altered foot mechanics itself can result in people presenting with hip pain. So analysis of the gait, the footwear, whether you have a fallen arch or not, looking at the knees, all important aspects in terms of trying to find out non sort of medical ways to fix your hip pain. Hopefully that answers it somewhat.
There was lots of detail there, Pravesh. Thank you. What are your thoughts on PRP versus steroid injections?
The latest guideline from the American Association of Orthopedic Surgeons that did the literature review basically said it doesn't work. Long and short, don't use it. It doesn't work. So that's the latest.
Okay, thanks. One more for you. Which implant is the best when choosing between plastic, metal, and ceramic in THR surgery?
That's beyond my scope. I do not know that answer.
Okay, perfect.
I think ceramic is what they use commonly in our area, but I don't have any research knowledge in which is better than the other.
Okay, good. Thank you. I think this is for Melissa. What types of jobs in the service industry would be examples that cause occupational causes of hip osteoarthritis?
So the ones that the service industry that they really was, and I kind of doubled back on it, was housekeeping was a lot. Even there were some mention of waiters, waitresses. You think of anything that they're having to carry, lift heavy physical loads, push, pull. Really, it was kind of a broad industry.
Okay, good. Did you find any differences, or are there any differences between females and males in wearing their duty belts?
No, I didn't. It was all just general. I mean, I could half assume that a lot of the studies too, it probably had more males, I want to say, than there were females wearing it. But no, that would be something to look at. I didn't notice any gender differences, and it didn't indicate any.
Okay. Do you have any specific recommendations on how to reduce the risk of hip OA from wearing the duty belt?
So there is research that there is a duty vest now rather than a duty belt, and it is suggested that it takes obviously takes the weight off the hips and allows for more mobility. And there's been research that shows that decreased complaints of our indications of discomfort and pain associated with wearing this vest compared to wearing a duty belt.
Okay, yeah, I've actually personally seen those vests, and they do seem to distribute all of the things that are on the belt a little bit more evenly.
Absolutely. It makes it more mobile too, even in their vehicles.
Yeah, I would be interested to see the negative repercussions of having that weight now pulled down on your shoulders, mind you. But
Absolutely.
they have to have the stuff somewhere, right?
Where there's one fix, there's always something else.
Exactly. Is there any role of welding work related to development of hip osteoarthritis? I guess better put, I'm assuming this question is, have you seen hip osteoarthritis in the welding trades?
I have not came across anything welding specific with regards to the hip.
Okay. Lots of questions here. Has there been any connection with those that sit for extended periods of time and hip osteo?
So in the reviews that I did, again, sitting was indicated as a factor in a lot of the studies as a contributor, but it seemed to be something that was more when it was in combination with something else. And just like I said, for every study that you find that supports that increased sitting can lead to hip osteoarthritis, there's one that says there might not be a connection there. So again, I think that's when you look back to the history, like what Pravesh was saying, like what other risk factors there may be, but there might be other risk factors on the job besides sitting as well.
Okay, perfect.
So just a further comment on that, I think the example Trevor gave of the sponge, when you don't allow it time to, resaturate again, if you just squeeze the sponge and you keep it squashed all the time, that's the static posture where your hip is not moving. So by not moving that hip, you're not allowing it to saturate and get its nutrients. So that would be one of the mechanisms possibly of why you increasing the chances of damage to that cartilage.
Perfect. Thanks, Pravesh. Thanks for that. Melissa, you mentioned the WSIB and employees who were denied from being injured at work. Can the employee request the WSIB send the file to OCAL? Obviously, I know that answer, but can you explain that process a little bit more for this individual who asked this question?
Yeah, absolutely. So you can request access to your file. Typically, advocates, so whether it's like a union paralegal lawyer, would refer the file to us. However, you can refer. We've taken files directly as well from patients that without any type of representation as well. You would just need to have access to your WSIB file. I don't know if you have anything to add to that, Dwayne.
No, that was good. I think that individual was just looking for a little bit more clarification. That's all.